we'll talk about the hierarchy of evidence. That's how we rank research design. What do they use to rank research design? Bias. Yes. And then the group that's not receiving the intervention, what do we call that group? Nice. And then one of the other notes I'll put on here, because we didn't touch on the quasi-experimental too much, so experimental research has to have a control. So in order for it to be an experimental research, you have to have a control group. When you talk about quasi-experimental, quasi-studies are like a before and after, and sometimes they have a control, but the whole point of the quasi-experimental is we use that when we don't have the means to find a good sample. So like, if there's a rare pediatric disease, and we go to a clinic to find the kids that have this rare disease, and we're going to do a study on them, there's really no control, but we're still trying to see how the treatment affects them. So we call that a quasi-experimental. There's no random subject assignment, sometimes not even a control. So I just wanted to clarify that because we didn't touch on that too much on the lectures. But in the book, those are on page 5, 6. It kind of talks about experimental, quasi-experimental. Case study, does a case study have a control? And we're just following one person throughout their plan, right? So just wanted to touch on that quasi real quick because I don't think we hit it too much in the lecture. All right, so when we're talking about intra-rater and intra-rater, can anybody tell me the difference? What's intra-rater?
Measures within yourself that you test.
Yes.
If you measure twice, it should be the same.
Yes, pretty close, right? What about inter-rater?
The difference measure it should be within
Okay, so if we took 2 PTAs and gave them a tool to use for an assessment, and they both got completely different numbers, but each of their retests were pretty close to their first test, would that be intra or inter? Inter. Easy peasy. Right. So when we get samples, what are the different types of sampling? So if I was going to go with a stratified sample, what would that mean?
They're already chunked off of their own. They're already chunked off of like their own classes.
Kind of chunked into groups already, right? So if we took, you give me a list of 200 people, and I just want the men from that, right? So that's a stratified sample. Random, what's a random sample?
Be a chosen random.
Just grabbing everybody, right? Everybody has a chance to be selected. And then systemic is,
Every certain number.
yep, perfect, sweet. So if I was to go on the college campus and grab 20 of the healthiest, most fit individuals to go do my test, and maybe all the athletes, I'll grab 20 of the athletes off the college campus to do a test on ankle mobility or shoulder mobility. What kind of sample is that? And then that is another good example of some sampling bias too, right? So if I'm just taking all the healthy people or all the athletes or something like that, then I'm going to have a biased study because my sample is a little bit biased. I'm looking for the healthies. Everybody understand sampling bias too? Right. So if I was to take a test, or if I was to give a test for low back pain caused by stenosis, and it came out positive in 95% of the people that really did have stenosis, but it also came out positive in a high number of people that don't have stenosis, what would that test be best at measuring? People that have stenosis or people that don't have stenosis? Say it again. Well, yeah, we're talking about that a little bit, but my question is if that I'm testing for stenosis, and that test gives me a 95% catches people that have stenosis, but it also has a really high percentage of people that may not have stenosis, they just have some back pain, so my test picks it up and says they have stenosis. Is that better for finding people with stenosis or ruling out stenosis? Ruling out. Because if that test says you don't have stenosis, you probably don't, because it catches the false positives too. Does that make sense? So with that said, is that a high sensitivity or a high specificity? It's a little bit of both. So you can have both be pretty high. So it's got a pretty high sensitivity because it's picking it up in everybody, right? It's catching those true, but it's also got a high specificity because if it says you don't, you probably don't. Does that make sense? All right, what's the purpose of inflammation? Absolutely, it's essential, right? We can't heal if we don't have the inflammation. What are the cardinal signs of inflammation? Slide 44 from that last lecture. Someone, one person, give it to me. Heat, give me another one. Redness, swelling, swelling.
Okay.
Sweet. What are the 3 phases of healing? What's the first one? Acute, inflammation, inflammatory. What's the second one? Proliferation. And the third? During the proliferation phase, would we say that that injury is pretty well healed, or would it still be pretty fragile?
Pretty fragile.
Excellent. During the remodeling, what's happening there? Yep, it's getting kind of lined up and organized a little bit better, right? Sweet. What percent strength is scar tissue? You guys did pay attention. Alright, so when we talk about healing by first intention, which just means some surgical intervention, we don't want to let that wound close up just yet because of certain things. What are some reasons why we might heal by first intention? Yes. Dirt in the wound, if there's an infection, we want to get that cleaned up and kind of not let it heal until we've got everything done. And sometimes the dirt gets stuck in there, so it takes time, a few repetitions to get everything cleaned up, so you're going to try and keep the wound open. What's your question? Healing by first intention.
Okay.
I think that's on slide 53. I tried to write this stuff down. So, perfect. The referral pattern of pain sometimes follows along the dermatome. What's a dermatome? Yes. Skin supplied by the same nerve root. What's another word for pain receptors? What's the fastest one? Yes. So what are wide dynamic range cells? They are T cells. They help to localize the burning, prickling pain. They help discriminate between touch and noxious itching. And then anything that has to do with motion or movement is carried by what type of cell? Mechanoreceptor. Alright. What's the biggest thing we need to know about the gate control theory? What's it do? Yes, but the biggest thing we need to remember about the gate control theory is that sensory stimuli can do what? Close the gate so we don't get the pain stimulus. Main thing to remember about gate control. And then last one, somebody tell me what edema is. Huh?
Swelling.
Yeah, but what is it?
Oh.
What causes the swelling? Pus. that contains a large number of white blood cells. And often, if you let it get out of hand, it's hard to decrease. Let's do it. You guys awake yet?
No.
All right, chapter 3, patient response to therapeutic interventions. Your learning outcomes. So the first things we're going to talk about today are some definitions: examination, evaluation, and intervention. So what's an examination? Get the history, relevant symptoms, administer the specific test, range of motion, things like that. An evaluation is the dynamic process that also includes and is done as part of the examination, where you use more clinical judgment that you've gathered. And an intervention is termed specifically, that means the purposeful and skilled intervention of the physical therapist or physical therapist assistant with the patient or client using various physical therapy methods and techniques to produce changes that are consistent with the diagnosis and prognosis. What's a diagnosis?
So what is wrong? Naming what is wrong.
Huh? Diagnosis is like a stenosis or, you know, bicep tendonitis. It's what's wrong. Okay? Prognosis means what?
Like the likelihood to recover, like the future prediction of how well
How
it
they
will
should
recover.
heal or
Yeah.
yeah. Good job. Diagnosis term they use to denote the disease or syndrome derived during the evaluation from the examination results. Yes, we don't talk about prognosis, but that just means what's going to happen, right? How well, what's the likelihood you're going to heal? Like when you hear those movies and TV shows where someone's got like, what's the diagnosis, doc? You have cancer, stage 4. What's the prognosis? Not good, right? Alright, you don't need to memorize these, but this is basically all the different modalities. Have you guys talked about CPT codes at all? Probably not yet. I don't know why this is in here. These are the CPT codes. These are a bunch of medical doctors and people like that come up with all of these things, and this is how we bill. So if you're going to do mechanical contraction or ultrasound for your billing, you're going to use these CPT codes. And you say 1 unit of 97035 is what you did today. I think that comes in a later course. I think it's just giving you a kind of introduction to what CPT codes are and what they mean. Those are just ways that the insurance companies and the billing people know what we did. So the importance of assessing a patient's response to treatment is critical in determining the success of any treatment intervention. And they say, you know, as PTAs, we don't do assessments. That's what you always hear, but I think that's kind of a weird thing to say because we should be assessing a patient every time we see them. Or else how do we know that what we're doing is working? So anytime someone comes in, you want to do some testing also, checking their range of motion, kind of like we talked about in lab this week, checking range of motion, palpating for tissue tone and things like that. And then you're going to perform your intervention, and you're going to reassess to say, hey, that did work, or well, that didn't do anything. Because if it doesn't work, you don't want to just keep doing ultrasound every time you see this person because you're not doing anything. So always check. That way we can tell if we're having success with our intervention. So the purpose of observing is to ensure the safety of the treatment, monitor the patient's progress, and adjust the dosage when necessary. Just like in the lab this week, we'll be doing the hot packs. Sometimes, especially when you're laying supine on the hot pack, people oftentimes will like, hey, can you throw another layer in here? Or if people were too cautious and they put a ton of layers in there, they're like, hey, I don't feel anything. Can you take one of these towels out? So we're just checking in during the treatment to see if you need to adjust anything. The application of agents primarily result in the modification of tissue inflammation and healing, pain relief, tissue extensibility, and modification of muscle tone. So while we're doing our assessments and checking on everything, we're going to look at a lot of the skin characteristics. So we want to look at the color, and that can vary day to day depending on weather and things like that. It could vary based on the amount of melanin in the skin. Continuity is looking for scars, blisters, rashes, or anything that's going to get in the way of any of the treatment modalities that we're going to perform. And then when we get into scar tissue, immature scars change a lot. They'll get a lot more red with, especially like heat and things like that. But the mature scars kind of don't respond as well. And with the immature scars, you also have a lot of times some sensitivity or lack of sensation around that area. But being that they're well vascularized, they're going to get really red when you put the heat on. Older scars usually stay kind of white because they're not as vascularized. The tissue's kind of settled. So when we're looking at uniformity of the skin, that gives us good information on their circulation, potential sensitivity to any of the thermal stuff that we're going to do. If it's pale or blue, oftentimes it lets us know that it's a little frostbite. And if it's pink or red, that just lets us know that we've got more blood flow to that area. So there could be some acute injury. And when you start putting on hot packs, people start turning pink and red because we're getting that circulation. If you hadn't put a hot pack on and that area is already pink or red, there's probably something going on in there. So we're talking about irregularities in the circulation. You can usually see those by appearance, and you can test the response and see how well their circulation is by doing a capillary refill test. Does everybody know what that means? Just poke your arm, it kind of turns white. When you take your finger off, it refills, and that should take about 3 seconds usually. Yep, it says it down there on the bottom. Color returns 3 seconds. But if it's greater than 3, that tells you there's a little less circulation there. And that's another word for that is just blanching. So if they don't have that return, then likely there's some inflammation in there or decreased circulation. Here's a picture of modeling. So just very spotchy, kind of red and white patches all over, and that's usually after you'll see that with doing a hot pack or a cold pack. If they get something like this, then that lets us know there's a good sign of either they're getting a little overheated or overcooled. And it's a warning sign that the underlying tissue is not going to be responding well to any of the thermal agents. So if you do something on someone one time and then this happens, you probably don't want to do that anymore. Just make a note, write it down, that way if someone else sees that patient, they're like, oh, you had a reaction. We're going to do something different today. Surface of the skin gives us information on circulatory status, so you want any warmth could indicate some inflammation. Coolness could be due to poor circulation. And then when you apply heat, it causes local vasodilation. So the increase in the surface temp gives you some erythema. Anybody know what that means? Yep. And possibly perspiration from the heat. Cold will cause a decrease in the surface temperature of the skin and cause vasoconstriction. But, so what this is saying, sorry y'all, I thought I looked through these, but that's good. So if you have cold for too long, you could have like a reflex vasodilation. So if you're in there for too long and you send those signals to the hypothalamus, everything constricts with cold. But if you're in there for too long, and it's rare I'll look at what page it's on too. You can get some vasodilation with that, and then that could lead to frostbite, but that's very, very rare. I'll find what page that's on in a minute. Let me take a break and I'll let you know. Typically, cold, we're going to remember, causes vasoconstriction. That's why it's good for use with acute injuries. So, any question on any of that stuff so far? So when we get into pain assessment, we talked about last week that pain's subjective and it's hard to define and narrow down, and that's why there's a million pain assessment documents and scales and things like that. So one of the first ones I think we talked about last week was the visual analog scale. That's where you just give them a sheet of paper, it looks like a ruler, and they mark down what the pain is on that. It's less subjective than the numeric pain rating scale, and it makes it more difficult for the patient to remember what they've said in the past. Because if I just give you the numeric pain rating scale, I'm just asking you 0 to 10 what's your pain, that's very subjective. I feel like I'm here. You give them a visual analog scale and it's got the little happy face pictures on there and stuff, and they kind of say, well, I thought I was a 7, but looking at this paper, maybe I'm a 5. So then it's harder for them to remember kind of where they were. Since it's hard to measure or document pain, it's important that you're observing their reactions and facial expressions during treatment, which I think we talked about. A couple of you guys asked me about patients with decreased mental capacity. Can we do hot and cold modalities on those patients? Because it is a precaution, and it's a precaution because they can't tell you, but typically still they're going to have some type of reaction, or their face is going to make a not so happy look, or they'll start squirming in the seat, and then you can go and add more layers or just be done. So it's a precaution. You can still do it, but you got to be watching, and you got to be aware of what medications. If they're on blood thinners and you're putting a hot pack on them, and you're increasing that circulation, or if you're putting cold and you're decreasing circulation, you want to know so that you can kind of time it out, or just be more mindful watching them. And then there's a pain assessment section in that chapter. I think it's page 20. What quote me on that? Yep, 20. Final answer. But it just talks about some of the McGill pain questionnaire, which we did last week, visual analog, and some of the assessment techniques. The McGill pain questionnaire differs from a lot of the other ones because there's specific terms. And this was on the slides from our last week's lecture. I don't know why I don't. But it's the one where it's got the picture of the body, right, front and back, and it's got, you can draw dashes or squiggly lines to mean numbness or itching or tingling. So not only are they pointing out where the pain is on the body, but they're also telling you it feels like this in those areas. It's multidimensional across the cultures. They've translated it in a lot of languages, and now they have data that correlates diagnosis with the selection of those specific terms. For like sciatic nerve pain, you have numbness or tingling. And if you see that they got those squiggly lines or whatever for numbness and tingling, it starts in the low back and goes all the way down the leg. That kind of gives you an idea of the diagnosis already, because you kind of know that nervy pain is numb or tingling, and you're seeing that referral pattern down, that dermatome. It's a lot more specific. So, a lot of times you want to assist them with the drawing because they don't have the cognitive ability to successfully complete it on their own. People always have questions. Well, it's numb and tingling, so which slide do I use? You use them both, right? Everything that you do. So sometimes you just got to help them out with some of those. And not just that questionnaire, a lot of them. We use a lot of questionnaires, especially on eval or pre-evals. A lot of times people have a hard time filling those out, or they forget their glasses or whatever. So, when you're questioning about pain, you want to avoid leading questions and statements. You want to avoid yes or no questions. Is your back hurting today? Oh, I bet that made your back hurt, right? Because now you're just giving them that information. Who can give me, other than these two, how are you feeling? Which I call this not a leading question, but it's not. I don't think how are you feeling is an open-ended question, because you don't want responses that could be good, bad, right? What does that feel like? Fine. To me, those still aren't open-ended questions, right? So somebody give me an example of an open-ended question.
I would want to ask one related to their goals, like if they're in for knee pain or like after a knee surgery and they're having their goal is to go upstairs or be able to run again. Like, I'll have the exercises that we did last session. Did you get any soreness? Are you feeling any stiffness today? I would ask if it's kind of related, but then I was like, have you made any progress going up the stairs or?
And some of those, like, can still be, you know, like,
A little
why
too
not?
specific.
Right? Yeah, but still, but those are good. Those are better questions, right? One of the ones I like to use a lot is people come in, I know what they're here for, all that, because you see them twice a week, right? So when they come in, I'm like, all right, what's talking today? Okay?
Just talking.
Yeah, what's talking? Wait, what's going on? Oh man, my knee is killing me in the back. I think I slept funny. Yeah, you get a little more information sometimes than, hey, what's hurting? Because what's talking just sounds weird. And then it doesn't have to be pain. It can be, oh, I got some numbness in my leg, you know? So it kind of gives them some more stuff to give you rather than what's hurting. But try to have a list. Think about some stuff. Get some open-ended questions. Try to think of stuff that's not leading the patients into telling you, oh, yep, sure did hurt. And then the ability to perform functional activities, range of motion can give you information on their current level of pain. And that's, again, what we talked about, do some assessment, right? Yeah, my shoulder's killing me. Well, you know, are you able to reach in the cabinet to get out plates or put plates away when you're cleaning the dishes? Let me see how I raise your arm for me. Let me see. And then I'll raise it and oh, well, it hurts right there. Can you go any further? Yeah, but it hurts even more. Okay, great, thanks. Right? There's a video. It's y'all can watch that later. All right. So, any questions about the pain assessments? Pretty easy. That was a leading question. Yes. All right. So edema we've already talked about. Abnormal increase in lymph fluid. What's it made up of? Plus white blood cells. That's one of our cardinal signs of inflammation. So when we start measuring it, we can measure it by Thank you. Circumferential or girth. So that helps us indicate the exact location and the quantity. We usually use a tape measure. We take measurements. You want to do them all at the same time of day. So what this is saying is if you take it at varied times a day, you can get inconsistent measurements because when they first wake up in the morning, they've been laying down all day, swelling maybe not as bad, but then they're up on their feet, they've been at work all day, they come into PT at 4 in the afternoon, they're going to have a lot more swelling in that area, especially if it's lower extremity in this example, than they do first thing in the morning. So if they're coming to see you one day at 4 in the afternoon, but then their next visit's like 9 a.m., you're going to get a huge difference, right? So you probably wouldn't take it. You want to try to do it at the same time. So I'd wait until they come back at 4 if I've already taken one at 4. Right? So that'll give us a better indication if we're improving. And this could also be due to medications like diuretics, activity levels, and then positioning. So if they come in and we're doing some ankle range of motion stuff with their legs elevated while they're lying down, do the ankle range of motion stuff, get the muscles pumping, get the blood flowing, get that circulation going, and then we take a measurement. And then the next time they come in and we have them sit down and we're talking, taking their subjective information, chatting for 5 minutes, and then we just go ahead and take a measurement there. Those are also going to be completely different. So you want to be the same every time you're measuring for any type of edema. Another way you can do it is volumetric water displacement. So when you get into distal extremities, it's kind of hard to measure with the tape measure, all of those areas, stuff like that. So you use the volumetric, where you get your tub and you fill it with 80 milliliters of water or whatever you're going to use, and then you stick their hand or their extremity in there, water level rises, you mark where it rises to. So again, you want to make sure you're doing that at the same time of day. For that one, you want to make sure the water temperature is the same, because if you throw a bunch of cold water in the bucket, if they throw their foot in there, that cold can help constrict the blood vessels, it may help increase it a little bit. If it's warm warmer, it might increase more blood flow. So you want to use the same water temperature and use consistent units and measurements. So you want to use, if you use milliliters the first time you do it, you don't want to use ounces the next time you do it. So we've talked about last week, prolonged edema can cause delays in the healing, cause pressure on the other tissues, and limit their functional performance or their ADLs. Everybody knows what an ADL is? Going on with soft tissue assessment, we're going to talk about muscle guarding. Usually this is due to to protect an injured area from further injury by shortening the surrounding muscles. So if my bicep was injured and you have me try to flex my hand to my shoulder, I might only go this far before that muscle kind of tightens up, triceps tighten up, not to let it go anymore. Right? So muscle guarding is a protection response. A lot of times, especially after like a rotator cuff repair, we're really limited the first few weeks of what we can do on that. So a lot of it's range of motion based. We're trying to stretch out the tissue as it's healing within the range that we should, like we talked about last week. So we want to go just before or just at that resistance, and then once they can tolerate more and it doesn't hurt, we get into the resistance, they're not going to pain, and more. We talked about all that last week. But when you're trying to do range of motion for those guys, a lot of times you might get like out to 20, 30 degrees and they're already going stop and their muscles are tightening up and you're getting tension, but it's not from the tissues that's healing, it's from the muscle guarding. So muscle guarding is just protection, and that's where we sound like a broken record, and 500 times in a row I have to say relax your arm, just relax, because they're guarding. You know, you can feel that difference whether it's guarding or that tissue restriction.
Is there a differential, do we differentiate between like the patient tensing up and the muscle itself like involuntarily spasming, or is it all muscle guarded?
It's the same thing, yeah. So, and that's what most of them are going to say is, I am relaxed.
Yeah.
I'm not doing anything, right? But it's just that involuntary reaction. It's that 9 times out of 10, they're not doing it on purpose. Right? It just happens. So, terminology is important when referring to motor responses of muscles. We have guarding. We also have spasticity, which is a motor response, and that comes from the nervous system, brain, spinal cord, where muscle guarding comes from the peripheral nerves, right? So they sense that movement, those mechanoreceptors light off, they send them further to the brain, and that's happening at that peripheral response, where spasticity is more brain and spinal cord. So like with traumatic brain injuries, or stroke patients, you're going to have spasticity rather than guarding. Does that make sense? Clear as mud. So prolonged guarding can result in shortening of the underlying tissues and feeling of hardening. So now the muscle feels harder than the surrounding area. And that's again when we're doing modalities and throwing heat on shoulders and traps or doing ultrasound. We want to feel for that tone, that spasticity, the guarding, whatever the case may be. And if they've had the shoulder issue for 6 months before they came to therapy, it's probably going to be in this area at this point. So when we feel it and compare this trap to this trap, one of them's going to be a little squishy and the other one's going to feel like a rock. Right? So then we perform our modality and then we look at them again to see if we made any improvement. So muscle tone refers to the resistance of the muscle to passive stretch. That's the tightness. That can get you contractures, either flexion or extension contractures. Muscle spasms mean increased tone. Make sense?
Mm-hmm.
The tone of the muscle where it starts to feel hardened due to prolonged spasm. So like we said, you want to palpate before and after. Ask for feedback while you're palpating. Sometimes it's painful. It's easy to assess, right? Touch right here and they jump off the table. Check. What if it's just a light touch? When I'm going to palpate, I haven't even pressed in to see if the muscle is hard or squishy. If I just touch their shoulder and they're already jumping off the table, what do we call that? We talked about it last week. Yes. Everybody remember that? Hyperesthesia? Right? Abnormal response to a light touch due to pain. Wake up. I know later on Dr. Shelby does an entire lab on posture, so this is just in here to kind of give you an idea of good versus bad. If someone's in this kind of noodle posture, what kind of tightness will we expect? What muscles? That's for sure. Yeah.
Spinal extensors.
Probably has some tightness and some scalenes and traps, even with levator. The head, and this is the way I always explain it to my patients that have tight levators or traps and things like that are walking around like this. All of these muscles are what's holding your head from just falling out forward. So if I'm walking like this, and I got a little more curve in my thoracic spine, if I don't move my head and I just fix my spine, so if I'm walking here, now I'm just going to come up like this, fix my back, and my chin's all the way up here at the ceiling. So all of these muscles are pulling me up, but they have to do it here, because otherwise I'll be looking at the ground. So you're definitely going to have some tightness back in there, tightness in those lumbar extensors, latissimus, all that stuff. Just a little look. A lot of times that arm guard, military posture is what we call it, because that's what they beat you in the head in the military. Chest out, shoulders back. So they're like the exact opposite of this guy. They're all here instead of here. So then you kind of get different tightness. But again, Dr. Shelby goes over. Did you guys do that class? You're standing out there with the marks and all that, and looking at postures. So when we're assessing the soft tissue, range of motion is a great objective measure. Everybody know what that is? Goniometer? That's what I thought I heard. Okay. Correct. It's important to look at both the quantity and the quality of the available motion. And limited range of motion can limit loss of function or lead to loss of function. So when we talk about quantity versus quality of the range of motion, obviously quantity is easy to measure that. What would the quality, or what would be some examples of some not great quality in the range of motion?
Like shoulder flexion, that's, I like that.
Go ahead, yeah, no, that's good. Keep going. You're on the right track. You're gonna say it, I know it.
It's like when you have a shoulder patient, like we're trying to get them to do shoulder flexion, but they end up involving like the trap
So
too much.
some
until
compensation,
it's, like,
right?
almost.
Exactly. Yep. That's exactly.
Limit to their ADLs.
Compared to their ADLs. Yeah. The biggest thing for me is that compensation stuff, right? That's number one. Because if I'm trying to check someone's shoulder flexion and they can get to here, and then after that they need to do this. They're not even flexing anymore. They're just shrugging their shoulder. You get to here? Is that as high as you can go? No, I can get to here. I mean, their hand went up, so to them, they're like, I did more. But they didn't. The other big common cheat that you see with shoulder flexion is they get to here, and you're like, is that as high as you can go? They go, nope. And now their hand's all the way at the ceiling, right? So to them, they're doing great. But shoulder motion didn't change. So then another one with that, I think in that same posture lab or class that Dr. Shelby does next semester, we do some manual muscle testing also. So you're assessing the strength of specific muscle groups or the arm, the upper extremity as a whole, or specifically external rotation, internal rotation. The biggest advantage you get from manual muscle test, the therapist usually, you can use a dynamometer, but it provides resistance when the patient's moving against it. So you give them the manual muscle test score from 1 to 5. Alright, but so you're giving them resistance. When you ask them to flex their shoulder out to you guys can teach that better than me, right? Y'all have that stuff now. And then you're gonna say, hey, don't let me move you, right? And you try to push on their arm with consistent pressure and all that. It gives you an idea, right versus left. Same thing if you're using the dynamometer for like grip strength. Squeeze that as hard as you can. Try the other side. It gives you great objective measures, one side versus the other. Also, if they have discomfort, or they can stop without any resistance or potential So if you start pushing on someone and you haven't given it your full push yet, you're kind of working your way into this. That's what y'all talking about, like kind of ramp it up. You're not like, right? So you kind of ramp it up, and as you're ramping it up, if they fall or they have pain, now you're gonna keep trying, right? So, and then that's not true for the use of free weights because you can't feel that. The most important reason to reassess whether or not treatment intervention is appropriate are for patient safety and improvements expected with all treatment interventions. So if there's no improvement, then either the intervention wasn't appropriate for that patient or that diagnosis, or maybe you did something wrong. Sweet. Cruising. All right, let's take a break. Any questions?
Volumetric.
Water displacement.
Volumetric, joint extremity.
So what are you learning then? What's the difference in the knowledge that you gain? So volumetric is only going to tell you that there's swelling or edema present. The girth is going to tell you exactly where and how much in that specific area. So girth is more specific. Volumetric is generalized to just say right there there's edema present. When we're doing volumetric measurement, we want to make sure that we're consistent in what ways?
Water temperature.
Yep, units, time of day, temperature. Okay. If we use the same tub of water, does that make a difference? Like if we have 3 tubs to measure volumetric edema, and I grab this one day and I grab this one the other day, that's what I'm saying. It doesn't matter. They're all measuring the same. All right. Therapeutic. First, we'll talk about temperature regulation. How is your body's temperature regulated? Hypothalamus.
Yes.
So, regulation occurs to maintain homeostasis throughout the interaction of local and neural mechanisms. Sensory receptors on the skin, muscle, and joints respond to changes in the temperature, and the hypothalamus maintains that normal range, which for humans is between 96.5 and 99.5, can all be considered normal. During COVID, you guys have to take your temperature all the time.
Always.
Places. What are your normal temperatures, like usually?
96.
Because mine's always like 97.5.
Mine's always like 95 or 96.
She's always heard 98.6, right? 98.6, 98.6. Because like you start measuring people's temperatures all
It's
the
like a
time.
high floor for me is 99.
It's varied. So normal is
That's a high
96.5, 98.5. So, the hypothalamus is your body's thermostat. So sensory information reaches the hypothalamus, results in activation of temperature regulating mechanisms, and causes either vasodilation or vasoconstriction of blood vessels. You also can get shivering or sweating to help regulate your temperature, and that's in response. That's some of those temperature regulating mechanisms. What does shivering do? Ow! What about sweating? How's that do?
Sweat
Ow.
evaporates off your skin.
I used to, for the longest time when I was younger, I thought like the sweat and the water just being on your skin is what made you cold. Like, oh yeah, because water. Like, I splash myself with water, right? But it's the evaporation. So different pathways for heat loss. We have skin, and skin is the major pathway, and then there's a bunch like your secondary pathway, and then they've got a couple other minor pathways. The biggest one we don't want to care the skin. So radiation and conduction is heat loss from the body to cooler air objects. Convection is when air currents move the warm air away from the skin. And sweating, excess body heat, sweat evaporates off the skin to cause that cooling effect. The respiratory tract, you get evaporation, so the body evaporates water from the respiratory mucosa and water vapor is exhaled. And then the other two, we have the urinary tract, urine's at body temperature, and so is feces, and the digestive tract. We don't have to worry too much about those. Skin is the most important thing that we're worried about. So when you get heat to your lumbar areas, the low back, you get an increase in subcutaneous blood flow, vasodilation in the distal extremities. So the increased blood flow removes heat from the area that is cooler, and it goes through the circulatory system and flows into the other area, resulting in a diminution of the potential increase. So patients with peripheral vascular disease already have restricted blood flow to the lower extremities. They might have difficulty tolerating heat even on their low back because it can cause that distal response, and they already have a hard time getting blood pumped out of the legs. So if you heat up the back, dilation, you get more blood flow down to the legs, and then that causes more swelling in the feet. So an increase in tissue temperature also correlates with an increase in the metabolic rate. So metabolic rate in the face of an acute inflammation means that heat could exacerbate the inflammatory process. So if they have some acute inflammation, some tissue healing, you may not want heat because they could get more. But there are also cases where they have decreased blood flow to an area where they can use some heat to help facilitate tissue healing by opening up the blood vessels and trying to get more of those white blood cells moving through that area. Mechanisms for heat exchange. Hot and cold agents have been used for centuries. The physical mechanisms can be delivered to the target tissue by conduction, convection, radiation, conversion, and evaporation. Conduction. Heat loss or gain between two materials with different temperatures in direct contact with each other. So in order for something to be conductive, conduction process has to be direct contact. So examples of that are like the hot packs, cold packs, the paraffin, all of that stuff you directly contact. And the heat is transferred from that material, the higher temp, to the material at the lower temp. Convection is heat transferred as a result of direct contact between moving or circulating medium, like air, water. Cellulose particles are what they use for fluidotherapy. So, anybody ever use a sandblaster? That's basically what fluidotherapy is. So like when you're working on cars or you're gonna paint something or whatever, it's got a lot of rust, you put it in this big box, you put your piece in there, and there's little pebbles, little beads, and they make it different kinds of mediums that you can use based on what you're trying to sand down. But you put it in there, you turn the machine on, and these beads just get tossed around by the air, and it peels all the paint off, and it gets it down to bare metal. Fluidotherapy is the same way. It's a softer medium, but it's a big box with all this cellulose particles in there, and then you put your hands inside the box through these little glove-looking things or whatever, and then you turn the machine on, and all these particles start moving around in there, and your extremities are getting kind of hit with it a little bit, and it's another way to do heat. But that's what fluidotherapy is. And then whirlpool is another example of convection because you got the jacuzzi on and the water's getting circulated in there, and then you get some of that, and then it's circulating medium, it's convection. Any question on conduction versus convection? What has to be true for conduction? Perfect. Radiation is transfer of heat energy through the air from the source at a higher temp to the source at a lower temp. The amount of exchange can depend on the intensity of the source, the size of the source, and the distance the source is from the treatment area. So examples of radiation are the infrared lights, ultraviolet lights, and the laser treatments. yesterday was telling me they were at a clinic that used the infrared lights. Have you guys seen that before?
Is that like if you go to gym, sometimes they have that big thing you stand in that's
The
just
red
the
light?
red light machine?
Yep. Yeah, red light machines like that, they have UV light like that, and then they have the lasers that get bigger and bigger. Alright, conversion of a non-thermal form of energy, meaning mechanical or electromagnetic or chemical, into heat. So factors that affect this one depend on the heat produced and the type of power or the energy source, size of the treatment area, size of the applicator, and the connective tissues. So examples of conversion are ultrasound is the biggest one that we use. And sometimes you can technically do cold packs because they're activated by a chemical reaction. Same thing with hot packs sometimes. Like the hot hands, when you open up the hot hands, you crack them together and it creates a chemical reaction that makes heat. That's conversion. You're taking something that's not heat, transferring it into heat. Just like ultrasound, we'll get into next week, is sound waves. So the ultrasound emits sound waves out of the ultrasound head, and that sound waves create vibration inside your body, and that vibration creates heat. So we're taking something that's a wave of sound and turning it into, so we're conversion. Okay? And then diathermy. I think we'll do diathermy in the lab too. It's electromagnetic energy. It looks kind of like a UV light. And then evaporation, you're transforming a liquid to a gas to release the heat, which causes the cooling of the tissues. And the biggest example of that is the sweat, but then the vapor cooling spray. It takes liquid in a can, vaporizes at low temperatures, and cools the tissue quickly when they're applied. So you may have seen some vapor cooling before. A lot of times sports and stuff, and stingers, things like that. They want to like put some ice on it. They don't have ice packs. They'll just hold up the hamstring and spray that coolant on there to create that evaporation. Any questions on those? The amount and the rate of energy exchange depends on several factors. First is the temperature difference between the hot or cold source and the target tissue. The bigger the difference, the faster the rate of transfer. So if you take a warm washcloth between the skin and an ice pack, it increases the rate of cooling of the skin. The intensity of the energy source. So the greater the difference in temperature of the energy source and the target tissue, the greater potential for temperature transmission. So ice lowers temperature faster than a cold pack, which I'm sure some of you found out in the labs this week. And the intensity is measured differently depending on the energy source. It must be monitored carefully to achieve the desired treatment results and to prevent tissue damage. Right, Sarah? And then the thermal conductivity of the tissues. So tissues with high thermal conductivity transfer heat more rapidly than tissues with a low thermal conductivity. So blood and muscle have high water content and absorb and conduct heat very rapidly. The periosteum of bone, which is highly vascularized and innervated, also absorbs heat and cold quickly, whereas fat, the outer layer of the epidermis, act as an insulator, and they don't absorb or conduct heat very well. And then metal has a high conductivity, so anytime you're doing any of these treatments, even just hot or cold, you want to make sure you don't have the metal there because that can make the hot more hot because it's a big conductor. Blood and muscle, periosteum, all of these things conduct heat quickly. Fat is a protective layer and it does not conduct heat or absorb it. Thickness of the tissue. The rate of temperature change decreases in proportion to tissue thickness. So like younger people with thicker skin versus an older person with more thin and frail skin. I mean, you see the older people, they just bump into something and they get bruised or everything's so thin and fragile. So that's another thing to take into consideration when performing any of these modalities. Thin tissue undergoes temperature change a lot more quickly than the thicker tissue. Size of the area being treated. The larger the area, the greater the total temperature change. So kind of looking at those hot packs in the lab, we have some of the smaller ones, little squares versus that big lumbar one. That's And then the duration of the exposure to the energy source. So the length of time needed for adequate and effective energy transfer depends on all the other things that we've talked about. So these are all things that you gotta keep in mind and be aware of whenever you're doing hot or cold or any other modality. Some of our physiological effects of the general heat application, we get increased cardiac output, metabolic rate, pulse and respiratory rate, causing vasodilation. Things that decrease are your blood pressure, your muscle activity, blood to the internal organs, blood flow to the resting muscles, and stroke volume. Therapeutic levels of heating can be mild or superficial, or they can be deep or more vigorous. Too vigorous heating has potential to result in tissue damage and pain. Heat from superficial agents like hot packs, lithotherapy, paraffin, all of that, generally go about 3/4 of an inch from the surface of the skin. So subcutaneous tissue that's well vascularized gets its maximum temperature increase within 8 to 10 minutes. This stuff's only going 3/4 of an inch deep whenever we apply it to something. And in the book, write this down, mild heating is referred to as anything less than 104 degrees. A vigorous heating would be anywhere between that 104 to 111.2. 5.2, I don't know. So between 104 to 111 is vigorous heating. Mild is what? Perfect. So if we go too vigorous, and we can cause damage to the cell proteins, is anything that's above that 111.2. So after 111, we run the risk of tissue damage and protein damage. Already talked about heat causes vasodilation. So when temperature rises, the body responds by increasing blood flow to the heated tissues. It's known as hyperemia. And that happens through vasodilation. It increases circulation, helps facilitate healing during the proliferation phase by bringing in more oxygen and nutrients and removing the waste products. One of the biggest disadvantages of vasodilation is edema formation, especially if the treatment area is in a dependent position during the application. What's dependent position? So dependent position would be where gravity has more effect, right? So, like if I'm working with you on getting your glutes stronger, and we're working, doing some clamshells or something like that, right? We're laying down on our side, working on some rotation, wrist clamps, whatever. We're moving those muscles, they're getting stronger. But then when I have you stand up and do a squat with a ball on the wall, then try to do some rotation at the hip, you can't do it. But now we're in a dependent position, right? So gravity has more of an effect, you're having to work a little bit. So like if I have you laying down and we're putting some heat on your calf, that's not a dependent position. But if I have you sitting up in a chair with your feet on the floor where gravity has more of an effect, that's more of a dependent position. That makes sense? So increased blood flow brings cooler blood, which removes the heat from the heated area by convection, and has a net effect of preventing excessive heat buildup in the area, unless the intensity and duration of the source are sufficient enough to cause tissue degradation. With increased metabolic rate allows for faster exchange of nutrients and oxygen and helps remove the waste products. which helps facilitate tissue healing during the proliferation phase. Tissue still in the inflammatory process of healing, heat can make it worse and exacerbate the inflammatory phase, which can create more inflammation, more edema, which is hard to get rid of, and can limit range of motion and slow down the healing. So if you have an acute injury or wound, would you want to put heat on it? Heat can reduce the pain perception. So, right, we talked about the gate control theory. The A alpha and beta sensory neurons take those enkephalins, close the gate, and the A delta and C sensory nerve fibers so the brain doesn't receive pain. So, the counter irritation theory, the alpha and beta neurons conduct impulse faster than the delta and C neurons. So the brain receives more heat information and perceives it more quickly than pain information. So by raising the nerve thresholds, therapeutic levels of heat can cause the nociceptors to become less sensitive. So the threshold of stimulation is raised, and there are fewer nociceptors stimulated. So that's why a lot of times in the clinic, after you've done therapy and stuff like that, you'll see people always get set up on some heat, right? Because doing that over and over and over helps desensitize the nociceptors and it decreases that pain perception, right? So we're not processing as much pain information, and then doing that more and more over time can help lessen the pain. Heat can also help reduce muscle guarding and spasms. So when it's sufficiently elevated, sensory nerve endings in the muscle spindle are inhibited by the sensory nerves in the Golgi tendon and result in a relaxation of the muscle contraction and guarding. So this helps us to break that pain spasm cycle that we talked about last week. Pain causes a muscle guarding, which causes pain, which causes guarding, which causes pain. So if we can reduce the guarding and get those muscles to relax for a little bit, all while decreasing our pain perception because we're firing off less of those nociceptors, we're helping to calm down the pain. So following the application of heat, muscle performance, both endurance and strength can be changed. So muscle strength decreases in the first 30 minutes after application of heat. So if you have someone come to the clinic and you're running behind and you're like, oh yeah, just put some heat on them for a little bit, their shoulders go up. And then they sit out there for half an hour before we can get out, or 15 minutes even. So for the next 30 minutes, their muscle strength, endurance, everything is going to be less. So after 30 minutes and for the next 2 hours, the muscle strength gradually recovers and it increases slightly above pre-treatment levels. So if you got people on heat prior to, it's going to affect if you're planning on doing some lifting and stuff, and they're doing less than they did the last time, and they can't do as many reps as they did, but they were on heat for 15, 20 minutes before you got to them, that could have something to do with it. And then we can improve connective tissue extensibility. So heat increases the elasticity and decreases the viscosity or the stickiness of the connective tissues in the muscles, tendons, ligaments, scar tissues, and joint capsules, which can increase joint range of motion. So increased elasticity, decreased viscosity. Permanent elongation of connective tissues will not occur unless the tissues are stretched. And stretching is more effective and less damaging when the tissues are heated first. That's why a lot of times treatment, even like we're not doing heat and stuff, if someone's got some tightness and guarding stuff going on, I'll typically go through and we'll do our workouts first. We'll do our therapeutic exercises. Because just the activation of those muscles, moving everything, it's like when you shiver, helps increase circulation, blood flow, gets everything warmed up a little bit, stretching at the end. It's typically what I tell people for their home exercise, because they always want to put heat on it. Can I do this? Can I do that? What should I do? When should I do it? I'll typically tell them, alternating heat and ice is pretty good too, especially for certain stuff. But I'll tell them, hey, when you get home from work,
before you do your exercises, throw some heat on there for 15 minutes, right? Get it warmed up, and then go through your exercises. Because most of the time, the stuff they're doing at home isn't strengthening, it's more motor control, things like that. But some of it could be strengthening. So put some heat on, do your exercises, and then stretch. And then when you're done, you can put some ice on, or you can't. Some people just don't like ice, right? So they just don't want to mess with it. Alright, so let's get into the indications, contraindications, and precautions. You guys have, everybody that's had lab this week already has these memorized, right? So general indications, everybody understands what indication is, right?
Reason to do the thing.
Reason to, well, reasons to do it. So if it's indicated, it means, hey, these are things that it's good for. So that's decreasing pain in subacute and chronic healing. Why subacute? Why not acute?
Because of the presence of the
Because it can make the inflammatory process worse on the acute stage. So subacute, chronic healing. To accelerate the healing, so if we need to put some heat to get some more circulation, get the metabolic rate up to encourage tissue growth and things like that. And then to reduce heat, or to reduce muscle guarding and spasm, relax the muscles, and increase joint range of motion. And I know that this one seems kind of confusing, that accelerate healing, because we're talking about we're not doing heat during the acute phase. And think of that as like we're not doing the fluidotherapy, whirlpool, moist hot pack, things like that. Where you start using heat for injury and tissue damage is when we get into ultrasound. So ultrasound can be used for both, like calming down some of this stuff, decreasing pain, reducing guarding, things like that. But ultrasound can also help promote, because it's not as deep, it's not as vigorous of the heat, it still heats up the tissue. We'll get to that next week. But so when we talk about tissue healing, that's usually what we're talking about. So contraindications are acute injury or the inflammatory process, if they're really inflamed, if they have acute or any potential hemorrhage, if they were mountain biking and they fell and rolled down a hill and maybe they got some hemorrhaging around the hips, maybe they got hematoma, something like that going on, we probably don't really do that. If they have fever, any malignancy, especially over any area that's treated with radiation, peripheral vascular disease, or any other circulatory issues, any dermatological conditions, dermatitis, sunburn, things like that, can all exacerbate with heat. And then during pregnancy, over the trunk and look back. Precautions, again, pregnancy, peripheral parts of the body of a mild patient become overheated. During menses, over the low back, increased blood flow, presence of sensory deficits, persons with impaired mentation or can't give reliable feedback, on elderly and very young patients who are not as efficient at regulating their body temperature and can easily become overheated. So all of those are precautions. So the first set are contraindications. So indication means, hey, this is what's used, this is what's good for, this is what could benefit from whatever modality or treatment is indicated. Contraindications are opposite. It's not good for this. It is not indicated. So contraindications, no. Precautions, just need to be careful. Doesn't mean that you can't do it. It just means that if you're going to use a specific modality, in our case, heat, you want to be aware of these things and pay more attention, stay closer to the person, maybe don't leave it alone, or don't use it over specific parts of the body, but you can use it elsewhere. So more precautions are any kind of cardiac disease, if they're taking beta blockers, things like that. Taking all the metals off any areas before you put heat. Any open areas of skin could be more sensitive, and over areas where topical drugs like Bengay or something like that are used. People do that all the time. They come in the clinic smelling like. So you gotta be, most of the time you're gonna know they have some of that stuff on. So potential adverse effects of therapeutic heat. Burns, so if you apply it for too long or if it's too hot, or if the tissues are just really thin and they don't have adequate circulation, you can get tissue damage from a burn or a blister. And then sometimes you have people faint. They have some orthostatic hypotension, so we get the heat on there, causes that peripheral vasodilation, causes a drop in blood pressure, and can result in less blood flow to the brain. So always have the patient stand up slowly after some thermotherapy. Have them do some ankle pumps or something like that before you stand them up. Some ankle pumps, some glute squeezes, stuff like that to kind of get the blood going back up. And then you can also cause bleeding. So certain conditions, vasodilation and increased blood flow can lead to a hemorrhage, which is why we're worried that there may possibly be a hemorrhage. You should put heat on. All right, everybody good so far? So talking a little bit about documentation. Again, this will come in a later course, but since we're going to start doing practicals, stuff like that, we need to get used to doing our documentation. I'm trying to introduce it earlier. Because last time when I was seeing people and I had them write a soap note, they still had not really any good idea on how to do it. So just trying to expose you to it sooner. So we'll go over a little bit about the soap notes and what goes where, and we'll start doing it for our practicals too. So every treatment that's given by a therapist must be recorded as a progress note. So documentation is legal record that proves treatment procedures were followed for reimbursement purposes and serves as a means of communication between clinicians who are working on that patient. So it's an ongoing record that helps chart a patient's improvement and progress or the need for a change in plan of care. Documentation procedures we learned in another course, but it's important to always keep in mind the information that must be collected and recorded. So our subjective information that comes from the patient. So this is all the stuff that you're asking when you start your treatment. Reports of changes in condition and function, pain rating before and after, comments about the last treatment, if pertinent, and if something crazy happened, they were walking their dog and another dog came by and their arm got jerked and now their arm hurts. Even if they're here for their low back, they have them doing some stuff that involves the arm. Not necessarily something we're going to treat. We're not here for their arm, but it may affect some of what we are doing for treatment. So anything that they're telling you goes to the subjective. And that's at the start and the stop. So a lot of times, and I still to this day am guilty of it sometimes, I try to put something in the assessment because it's an assessment, right? So I'm trying to put what they told me after the treatment, like, oh hey, yeah, my back feels much better. Hey, I can move my leg more now, right? That still goes in the subjective. So anything that they say is subjective. And then, like we talked about, this is important too, just to keep a record. So if they fell down or something like that, you have a record of it. If later on it needs to be brought up, if the doctor asks, whatever. But also, if I'm seeing somebody and I've seen them for the last 2 weeks, twice a week, so I've seen them 4 times, and now they're coming back on your schedule. You haven't seen them in 2 weeks. This is going to be a great way for you to kind of stay on top of how they've been. You can go back just one note, you go back a couple notes, and you can kind of read before you see them in prep, like, oh, this is what they said last time. Oh, hey, they had this happen. You know, whatever. It's good to have all that. Everything that they're telling you, especially if it's pertinent to what you're doing.
It also really helps like build that relationship, like that trust between therapy guys. They come in, they haven't seen you before, you go, hey, how's your shoulder? Like, I heard last time we fell on you, so we needed to do some modifications. They're like, oh my gosh, this person's never seen me before, but knows about my shoulder.
It's huge. I mean, it goes a long way for patients. And typically, what we'll do, if I notice, we'll look at our schedule in the morning, and I'll see that, oh, Ryan's got this person that he hasn't seen in forever because it's only been me and one other therapist working, and now they just needed a time slot. He had one open, so I'll just go down to his treatment room and I'll be like, hey man, you're gonna see this person today, or I'll shoot him an email. So like we'll email or just kind of chat each other up, like, and not just like treatment stuff, but hey, he played golf for the first time last week. He was only able to do 9 holes, but if he needs a golf cart, he walked. He's like super excited about it. So like you
like patient pain level, 1 out of 10 at the beginning, or whatever, and then it would be,
Subjective.
so, would it then range of motion, so
We're
we
into
should,
it.
because we let
It's
it go.
objective.
So what was the assessment? Because that would be.
We're only on the
more-
S, man, give me a minute.
We're about to go through it all. We're going subjective, then we're gonna do objective assessment, and then the plan. So that's what I'm saying. It's hard to kind of figure out where everything goes. So anything that they tell you, so a pain assessment, if I've asked them before and after, changes of condition, pain rating before and after, all that's subjective. And then we start talking about measurements, we get to that stuff in a second. So it's coming. Bear with me. Any questions about subjective though? Alright, so for our objective, is information that the clinician gathers during treatment, such as observations and assessments for like palpation, muscle tone, tenderness, skin condition, edema, range of motion, functional abilities. So we record observations and measurements that are problems pertinent to the patient's goals. I also will throw in the shoulder stuff, like in my last example, like if we're treating their lower back, but they did something over the weekend and hurt their shoulder, I still put that in the subjective, and I'll still comment on my objective because, hey, they weren't able to do this, or this exercise today because the shoulder pain was limited, not because of their back pain. So like when someone else sees it and sees, oh, they did less repetitions or they weren't able to do that exercise today, they have an idea of why. It had nothing to do with their back, it's because their shoulder was hurt over the weekend. So you really want the stuff pertinent to the patient's goals and why they're being seen, but also for instances like that, I still kind of include stuff if it affects the treatment. I'll put it in there. The treatment administers any equipment used, the method of application, perimeter selected, and the area treated. You'll put the position the patient is in and duration of the prescription. So like with a moist hot pack, if you had a patient come in and we're going to put a moist hot pack on the lumbar spine, but I'm going to have them side lying on their right side because they can't lay on their left side because their shoulder hurts, right? And then they have a bum hip, they've had a hip replacement, they don't like laying on their left side, so I lay them on their right. All of that's going to be in your objective. So end of treatment, whatever we did, moist hot pack with 6 layers, 8 layers, whatever. Right side lying, pillow between the knees for 15 minutes. Done. When we start doing any ultrasound or electrical stimulation stuff, what mode did you use? What hertz was it at? What was the frequency that it was at? What was the intensity on it? All of that goes into that objective. So we did ultrasound with 3.3 hertz at 15 frequency. All of that blah, 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 blah for 10 minutes over this area, and the patient was in this position when I did it. So everything you do. And then if you're doing therapeutic exercise, if you're doing wall sits, we did 5 wall sits for 30 seconds each. And then we up and down, ascended, descended stairs, 10 steps times 2. How many times you did it. So all of that goes in there. That way the next time the person comes in, they see somebody else, I can look at it and be like, all right, we did the steps twice last time. I see one of your goals is 3 because you got 3 flights of stairs to get to your apartment. Let's go hit it again, see if we can get that third objective. Any questions on the objectives? Easy peasy. And then the assessment is where we summarize the effects of the treatment for the patient's problems, comments to the patient's progress towards or achievement of their goals. So assessment is what you observed out of the patient in regards to what you performed, right? So if they had an adverse reaction to your moist hot pack that you did in your objective, and the skin got really, really red, you're concerned that like if they would have gone any longer or if it was any hotter with less layers, whatever, then you could have gotten a burn. That's what I'll put here. Right? So hey, we used 8 layers, but your skin was really red, I'm concerned. Maybe in the plan we're talking about having layers, but putting that down. They went up 2 flights of stairs, but after that second flight, they looked like they were about to pass out and they needed like a max assist to get back to a chair. And it was really concerning me, right? So that gives the next therapist an idea of, oh, instead of me just looking and being like, oh, they did 2 sets of stairs? Sweet, let's get 3 today. I'm probably not gonna try 3 if in the assessment I saw after that second flight they were about to pass out and needed max assist to get over to a chair. So
would, and again, you can kind of go, absolutely, you're checking their skin before and after, but then subjective is more basic, right? So they're not gonna see their lumbar back as getting close to maybe having a burn. That's something that I'm assessing, where subjective is what you're telling me. Does that make sense? Kind of? Because like after the treatment, I take the moist hot pack out. How do you feel? Subjectively, great. That heat was amazing. It was wonderful. Doesn't hurt or anything. Nope. But I'm seeing that we were close to getting a little too much heat. So that's me observing. Does that make sense? Kind of. You're not gonna be wrong to put it in place. I'm just trying to give examples of put for that assessment, and that was where I would put that because again, to them subjectively, they were fine, no problem. But me, as a therapist, I can assess that, hey, that was a little bit too much, either too long, 4 layers, whatever. Maybe that was a bad example. Yes?
So you said it's what you observe after your objection, your objective?
It's how they tolerate the objectives. So if we did bicep curls with 50 pounds, and they were able to get a half of it, right? And put that here, that, hey, 50 might be a little too much.
Okay.
Is that kind of making sense?
I was gonna ask, like, so the objective, that'd be like what you did, and the assessment, that'd be the result of what you did, and then whatever they say, that would be the subjective.
Yes. It's not necessarily the result. I mean, yes, that's but it's how they
The
tolerate it.
effect.
Right? Yeah. So like sometimes I'll put, we did hip hinge with a 12-kilogram kettlebell, right? And we did 2 and they started having pain. Pain would be reported in their subject, but in my assessment, I'm going to put that they had pain after the second rep of a hip hinge of a deadlift, right? They had pain after the second one, so we stopped it. Or they had pain after the second one, corrected the form, and then they were able to do the last 8 or 17. I'll put that here because it's how they responded to the image. So they responded negatively because they had pain after 2. But then corrected the form and they were able to finish it. So like pain after 2, form corrected, tolerated, 17. Would be my assessment. And it's cloudy and it's crazy, I know. But just the best you can, and the more you start doing these for practicals, not just in this class, but in Dr. Christie and Dr. Shelby, the more you do it, you're gonna get feedback from us, and we're gonna say, hey, I would put that here, I would put that over there. And then the more you do it, the more you kind of just start finding where you place stuff. And people do it differently too. Some people would put anything, like what we just talked about, like adjusted the form, could technically go in observation, or because it's something that we did. I gave them verbal cues to fix their form, so technically they can go like, oh, but I will put it here.
So, under the O, that'd be like your education that you'd put in for, like in how many minutes you did it. So your objective is just your flow sheet.
Basically.
Okay.
Yep. And sometimes with like, and again, all these SoCo stuff is from way back in dinosaurs were still walking the earth, and we wrote everything out on paper. And we would write S, we would write everything there, we would write O. Like, nobody really does that anymore. Now, most of the time, everything's in electronic medical records, and you still have your subjective, you just type everything they say. Just type what they say. And then you go to the objective, and it's flow sheets, and it's click, and it's, a little bit here. There's places, some flow sheets have little comments that I can put corrected form twice, or needed mod assist twice, or whatever, on the flow sheet. So it's kind of just all wherever, right? And then there's still usually an assessment where you type in how they responded to the treatment, how they tolerated things, and then there's still the plan at the end. So a lot of it now is more streamlined. You don't have to be SOAP, but just kind of understanding what you need to put. And the biggest thing that I think you take away from this is the O and the A. The O is writing down everything. Be as specific as possible while still being concise. Because you don't want a 2-page paragraph of what you did in the objective. Because now when I'm about to go grab this patient out of the waiting room, I'm already 2 minutes past their appointment because I had to clean up and put some equipment away. Now I need to read about it real quick. I don't wanna read through 2 paragraphs. I just want the cliff notes. But specific, include all the frequencies and every detail that you can. And again, it just comes with practice. I remember first doing soap notes and I just couldn't grasp the concept. I didn't know what went where. Every time I turned one in, they were telling me to move stuff around. Didn't understand it, but now it just happens. And just one of those things you gotta do, which is why I want to start doing it even before you have class. Because then by the time you have a class, you're gonna be like straight A's. All right, we good on the SOAs so far?
Yes.
Right. So then the plan is our plan for the next treatment. So you can have specific instructions. So you can have recommendations for home exercises, any additional education they might need, instructions, changing the plan of care, change the ice pack, whatever, add exercises, or recommendations for discharge if their goals are met. So we can't discharge people, but if we're seeing someone and we're going through all their goals that they started when they first came to therapy, and we've hit all of those, things are looking good, finish this treatment, and in my plan, I'm gonna say, discuss with PT, possible DC, right? And then I'm gonna email or go to the therapist that did the eval and be like, hey, this person's doing great, I think they're ready for discharge, and they'll say, cool, and they'll write in discharge. And then any substantive changes to the plan of care, reevaluation if we need it, correct rules. In South Carolina, for Medicare specifically, we try to just keep it the same across the board. Every 10th visit, 30 days. We have to do. So, if I'm the only person working with this patient, and it's been 4/5 week, we're getting 5 weeks in twice a week. We're getting close to our 10th visit, 30 days, whichever comes first. Right? So at that point, 10th visit, 30 days, we have a therapist to do a reeval or a progress note. Reeval is more for like when they run out of their certification range. I'm talking about stuff that you don't even need to worry about yet. Progress notes are easy. A lot of times I'll do the progress note because we can type it all up, we can do all the things, and then the therapist has to sign off on it. So usually if I'm doing a progress note or something, I'll go through all of the measures, the same goniometric measurement stuff that the therapist did on eval, so they have something to compare to, and then I'll grab them and say, hey, come by and check on this person so they can make contact. How you been? I see you're progressing. Yep, great. Now they feel comfortable signing off on the note. Easy peasy. So, anyway, that's getting in the weeds a little bit. That's the plans. All right. How's everybody holding up? Say something.
Good, great, Dan.
Alright. I made another slide last night. Because I got through this and I was going through everything. I was like, man, they didn't talk about cold a lot. So I just made it's only 3 slides. So I made another one just to kind of hit the highlights of cold. I don't know. It was just weird to me that we didn't talk about it yet. Like we went through contraindications and precautions of heat. We did for cold. So one more, it's only 3 slides, and it's just hitting highlights. Any questions so far? Great. Therapeutic cold. I just wanted to put in here our contraindications. So, cryoglobulinemia is where the blood proteins start to form a gel when they're exposed to cold. And if that's like that for too long, you have the risk of developing gangrene, you get that infection, and then you just got contraindications. So, we don't want to put cold on people that have cryoglobulinemia. They have Raynaud's, which is cycles of pallor, rubor, and normal coloration in the hands of people. So pallor meaning white, rubor meaning red. And this picture is a picture of someone that has Raynaud's. So you got the white, you got the red, and you got the normal. It all kind of happens at once, and that can change. Like this finger goes back to normal, and this one gets white. You know, it just kind of alternates. I have a patient now, or over the summer, that had, we had the air on full blast in the middle of summer one day, and she came in, and she was just sitting there while I'm getting her subjective. And she's like this, and I was like, "You good?" And she's like, "Oh, I have Raynaud's." She showed me her hands, and that's what they look like. And it's summer outside, but we had the air on, and that air just being that big of a temperature change set her off a little bit. So, if someone's that sensitive, they have this. It's very, very rare. She's the first person I've ever met in my life that actually has that. But you would put their hand in an ice bath. So that's a contraindication. Cold urticaria, which is where you can get local rashes or welts, itching. You can get some raised areas on the skin, stuff like that, for the local response. But then people that actually have the cold urticaria also have systemic response, where they get real flushed, their blood pressure will drop, heart rate goes up, and they can potentially pass out when exposed to cold. And then the last one is the hemoglobinuria, that word, which is basically blood in the urine. So you wouldn't be able to see that in the clinic. Like, they would have to know that, and or after you've done a cold treatment, the next time when you're getting your subjective, how'd you do after last treatment? Oh, it's fine, you know, blah, blah, blah. It's blood, which they may not tell you, so that one's tough. But if they know that they have that kind of issue, we wouldn't do that for those people. And then also loss or decreased sensation in the area, right? Which, some local anesthesia, maybe, perhaps. We wouldn't put cold on there because they wouldn't be able to feel it or tell us, right, their skin's falling off. So, picture of Raynaud's right here, and then that is all the welts and bumps and stuff, which is that cold urticaria.
Are you gonna put this on?
I just, when I added it the last time, it was like 11 o'clock last night. I put it in the course, but it's like, I just gotta unhide it.
Oh.
So I'll do that in just a second. And then just same thing we did with the heat. I wanted to give you the goals, which obviously are pretty similar to heat, except for you can get better edema reduction. You still get pain reduction. You still get the muscle and spasm reduction. So cold applied to the skin causes vasoconstriction, because that other slide was confusing to me, so I rewrote it down here. So the lower the temp of your skin gets, it activates free nerve endings that result in that vasoconstriction. And the longer it stays that way, it stimulates more information to the hypothalamus, and that's where you can get into that vasodilation. And I'm gonna look at what page that is too, so you guys can look back at that before we finish today. But that's very, very rare. It's not gonna be on the test, but just so you can understand it, look it up. And then that's the ice bath. Since everybody loved the ice bath in lab, I figured I'd put a picture of that. And then since we didn't do the ice massage, they're using styrofoam. I always use Dixie cups, but either or, right? Freeze that water, and then you can peel off layers as it melts, and your hand doesn't get frozen quite as much. So those are those. Where am I at? Cool. Probably start 77. 77. And then it flips over to 78, where it says vasodilation has been reported to occur in response to extended exposure to cold, and then it kind of goes through the theory of what causes that. Also occurs with the cycling component and attributed to local responses in the deeper tissues. So it gives you a little more information on that, the vasodilation with cold. I'm not going to test you on it. It's very rare. It doesn't really happen. For us, we want to know the vasoconstriction with therapy. Sweet. All right. Now, we got done early. Now is the time if you have questions, if you need clarification on anything. These chapters, or last week's chapters, we have a test next week. So now is a good time to ask questions, go through your notes, hang out for a little bit. I'm done. This is everything I've got. So it went faster than I thought. I'm still here. So go through your notes. We're going. There's need if you want to. Just kind of saying. That's what I'll let you do. I'll let you do. If there's any questions, let me know. Other than that, let's call it a day. Don't. I was going to.
Well, then shut up.